Hello, and welcome to this presentation on hereditary prostate cancer. My name is Alexandria Meyer. I'm a genetic counselor. I was in clinical practice as a cancer genetic counselor for approximately 7 years before I moved to Ambry Genetics, which is a private diagnostics lab in Orange County, California, which performs hereditary cancer susceptibility testing. And I'm very pleased to be able to speak with you on this subject today, as it is one that I find to be very important, but perhaps overlooked. I'd like to begin by having you keep in your head a particular case example or a scenario which likely you have seen in clinic many times before. A 48-year-old gentleman newly diagnosed with prostate cancer, Gleason score of 6, oncotype score is somewhat intermediate, and as a result of all of this, the patient is expressing reluctance to undergo treatment, is kind of leaning towards the wait, watch, see what happens approach. And like I said, this is probably a scenario you have seen several times in clinic, but what you may not have realized is that this is a scenario in which hereditary cancer susceptibility testing may actually help clarify what the next steps for this gentleman should be. As a genetic counselor, I tend to get the same questions over and over again from providers when they hear about how, well, maybe genetic testing could help with a scenario like this, and they tend to ask things like, well, who is genetic testing appropriate for? How do I go about performing genetic testing? And the biggest question is, why? Why should I be performing cancer susceptibility testing? What benefit does it have to my patient? And I'd like to address each of these in turn. When it comes to identifying patients at risk for hereditary cancer in your practice, there are often red flags or signs for hereditary cancer that you may have missed in the past or have not recognized previously. Some of the potential signs of hereditary cancer will come in the course of conversation with your patient. As they're discussing their personal, family, or medical history, they'll give you clues that there are signs of hereditary cancer in their family, such as, my dad and my brother both had prostate cancer. This is the second time I've been diagnosed with cancer. It doesn't seem fair. Isn't 45 young to be diagnosed with prostate cancer? They realize that they have an aggressive prostate cancer, perhaps by their Gleason score. Or they report that they don't have a family history of prostate cancer, but, for example, their mom and grandmother both had breast cancer. And these are all potential signs of hereditary cancer, but ones that have largely gone unnoticed by urologists. And that kind of begs the question, well, why is that? Why is the urology community not really noticing these red flags? Personally, I think part of that has to do with the fact that hereditary cancer susceptibility testing has traditionally been thought of as something for women. Women need to undergo genetic testing for hereditary breast and ovarian cancer. When we think of BRCA, we think of women, breast ovarian cancer. We think of Angelina Jolie. And yet, we know that hereditary cancer impacts men equally. Men are just as likely to have a hereditary mutation as is a woman. These genes are not on the X chromosome or the Y chromosome. They're on chromosomes that we all share, and men and women are equally as likely to inherit a mutation from a parent, to pass it along to their child, and so forth. So we know that men can inherit cancer susceptibility mutations, but one of the questions that I get from urologists is, well, how common is this in men with prostate cancer? And there's a growing body of literature which seems to suggest that it's a fairly significant proportion. Our own internal data at Ambry suggests that about 14.2% of men with prostate cancer will test positive for a cancer susceptibility mutation, and this is in line with what other studies have seen as well. A study out of Tulane Cancer Center found that about 16% of men with prostate cancer who were unselected for any other factor tested positive for a mutation. And a paper that got a lot of attention about a year ago out of the New England Journal of Medicine found that just under 12% of men with metastatic prostate cancer tested positive for a cancer susceptibility mutation. And I think they were particularly interested in the metastatic prostate cancer population because those gentlemen, once a mutation is found, become eligible for PARP inhibitor therapy. So there's a therapeutic benefit to finding mutations in these gentlemen. And if you look at the graphic on the right, you see that of the genes that these mutations are found in, it's not all BRCA1 and 2. Certainly they make up a significant proportion, but there's other genes that work as well, and the vast majority of these genes have medical management guidelines associated with them. So anytime we're finding a mutation in one of these genes, we are able to make recommendations for the patient as to how to proceed with their medical management. So the literature seems to show that about 1 in 7 men with prostate cancer have a hereditary mutation. So how do we go about identifying those 1 in 7 men? Well, if a man already has prostate cancer, there are things we can look for in his personal history, such as young age at diagnosis, meaning before age 50. If the prostate cancer is metastatic or particularly aggressive with a Gleason score of 7 or higher, if he's had more than one primary cancer diagnosis, if he has prostate cancer plus a family history of cancer. But since our ultimate goal is to identify men before prostate cancer or any other cancer is diagnosed, we want to look at the family history. And that includes 3 or more prostate cancers on the same side of the family, or other cancers as well. If there is prostate, breast, colorectal, or uterine cancer diagnosed before age 50 in a relative, that can be a sign of hereditary cancer. If you see rare cancers such as male breast or ovarian cancer in a relative, or if you see 3 or more family members specifically with breast, ovarian, prostate, and/or pancreatic cancer, those cancers are all associated with the BRCA mutations, which are the biggest culprit in hereditary prostate cancer. Not the only culprit, but the biggest. So to summarize that, this is what we want you to remember about identifying the WHO in your practice. Approximately 1 in 7 prostate cancer patients have a hereditary mutation. If they have metastatic or aggressive prostate cancer, they should be considered for testing. And the family history is critical in identifying men at risk for prostate cancer. Keep a special eye out for a family history of breast, ovarian, prostate, and pancreatic cancers. So that's the WHO. Hopefully I have convinced you that there is a significant proportion of men out there who have these hereditary mutations. But why does that matter? Why should you care about finding these mutations in your patients? I would say first off, one of the things I like to say is that urology is sometimes the first opportunity for these men to really sit down and talk with a practitioner about their family history. Sometimes it'll be picked up by their primary care provider, but many oftentimes not. And men are notoriously, stereotypically, known for not going to the doctor very often. And so if they get in front of a urologist, of a specialist who takes a family history, that may be one of their only opportunities to have their family history given some attention. In addition to that, we know that there are demonstrable benefits to genetic testing. A patient can make medical management decisions based on the implications of a mutation. It can identify and clarify their risks for cancer, and it can identify at-risk family members. So not just the patient, but their family members can determine if a mutation is present and what medical management steps should be taken. And there are pitfalls to not performing genetic testing. We saw in some of our data at Ambry, and this was backed up in additional studies, is that majority of men with mutations had prostate cancer and another cancer at the time of testing. So they had to get a second diagnosis of cancer before someone paid attention and offered them genetic testing. And in some cases, that second cancer was preventable. If we had known a mutation was present, we could have prevented that cancer from occurring. And vast majority of those men could have undergone testing. They met criteria for testing by their insurance company before that second diagnosis of cancer happened. So it didn't need to get to this point. To highlight why genetic testing is important, why there are definite implications, let's go back to that case example that we had at the beginning of the 48-year-old man with an intermediate score prostate cancer who was expressing reluctance to undergo treatment. In this case, a particularly astute clinician went ahead and took a family history and found that in addition to the prostate cancer in this gentleman, he had a family history of prostate cancer in his father and early onset breast cancer in a paternal cousin and aunt, as well as pancreatic cancer in his grandfather. So the clinician ordered a 13-gene panel called Prostate Next on this patient, and it turned out that he had a mutation in the ATM gene. The ATM gene increases risks for prostate cancer, but also pancreatic cancer. And men who have ATM mutations who develop prostate cancer are much more likely to have that prostate cancer become aggressive. It's much more likely to become metastatic. And men who have ATM mutations who do develop metastatic prostate cancer have different therapeutic options available to them, such as a PARP inhibitor. So once the gentleman learned of his mutation status, he became much more interested in treating his cancer. He also became a candidate for pancreatic cancer screening. And I know you're sitting there saying there is no screening for pancreatic cancer, but actually individuals who are at high risk for pancreatic cancer, such as people with ATM mutations and a family history, can undergo screening via endoscopic ultrasound or a similar method through high-risk programs and clinical trials, which is what this gentleman chose to do. His family members now had the option of being tested to see if they carry the mutation. Female relatives who had the mutation were advised to begin annual breast MRI in addition to mammography because of the high risk of breast cancer. Male relatives were advised to undergo more frequent surveillance for prostate cancer, and both were advised to consider pancreatic cancer screening. So it was great that we were able to find the mutation in this gentleman and kind of put him on the right path for managing his cancer risks. But our real goal is beating prostate cancer at its own game, is perhaps finding it early. And genetic testing can help with that. It can help us get ahead of the disease by understanding what a patient's risk is before they ever develop cancer so that you can make more precise medical management recommendations. Since we want to identify these men before cancer happens, we want to remember to ask about the family history and look for these signs in particular. Here's an example of how that might work in practice. This is a 45-year-old gentleman who was referred to practice for a diagnosis of microscopic hematuria, which was found during a routine annual exam. He came to see his urologist. Turns out it was just a bladder infection, and so typically urologists would have given this gentleman antibiotics and essentially sent him on his way. However, this urologist noted that there was a family history of prostate cancer and ovarian cancer, and that set off some warning bells in his head. And he ordered genetic testing, and lo and behold, this gentleman had a mutation in BRCA2. Now, most of you are probably familiar, at least someone with BRCA2, and that there are dramatically increased risks for cancer associated with those mutations. This is just a reminder of the increase in those risks, particularly breast, ovarian, male breast, prostate, and pancreatic cancer. Given this gentleman's increased risk for prostate cancer, he would be advised to undergo prostate cancer screening by PSA and digital rectal exam beginning at age 45, and typically the recommendation is for that to occur every 1 to 2 years, regardless of what is seen on the exam, since we know that these cancers can be aggressive and develop quickly. So this gentleman should be returning to your practice every 1 to 2 years to undergo screening. In addition to that, as a reminder, if we do find a prostate cancer in this gentleman, we know it's more likely to be aggressive. And for that reason, we want to keep a closer eye on him, make sure that the cancer doesn't get to this point. Plus, we want him to keep in mind the risks for other cancers, such as male breast cancer, pancreatic cancer, and melanoma, and possibly consider screening for each of these cancers as well. Impact for family members cannot be ignored. Women in his family can get tested to see if they have the BRCA2 mutation, and that's particularly important for them because cancer risks are often very high and largely preventable. For women who have BRCA mutations, risk-reducing surgeries are available to these patients. So the overall benefits of genetic testing, if I can kind of sum up what we've learned from our case examples: improved management of men with prostate cancer. You want to consider more aggressive management of men whose prostate cancer has not yet metastasized. We want to identify men who are at high risk for prostate cancer. We recommend increased surveillance to detect early prostate cancer, and we also recommend surveillance and possible prevention options for other cancers. And of course, there's benefits to family members. Relatives may be tested to learn more about their own cancer risks, and if they do have the mutation, they will be given their own personalized surveillance and prevention options. As far as how you implement genetic testing for hereditary prostate cancer, there are many tools available to you. So if you agree that this is something which deserves your attention, here are some of the tools that can help you. Step 1, collect the family history. We do have a form at Ambry Genetics that can help you with this if you don't want to create a form of your own or you don't already have one in practice. And there's other family history forms circulating around the web. Step 2 is determine who meets testing criteria. That's actually very simple. Again, on Ambry's form, we have it right there on the form to help you if you are interested in that. But criteria for hereditary prostate cancer is also widely available on the web and available for you to look up and create your own tools and resources. You can consider utilizing a multi-gene panel. The panel that we have at Ambry is called Prostate Next, and there are other panels out there as well. However, if you think that collecting the family history is about the extent of your ability to get involved, you do have the option of referring patients to a genetic counselor who can educate your patient, get informed consent, facilitate the ordering of testing, go over the results and the management recommendations and send those to you. You can find your local genetic counselor at www.nsgc.org, or there are multiple telehealth genetic counseling services available. And again, those are easily discoverable online. So to sum up, prostate cancer can be an indicator for hereditary cancer susceptibility. Genetic testing is grossly underutilized for men as of right now. Identification of a hereditary mutation has prognostic, therapeutic, and familial implications. Urologists are often the first line available to men in identifying their risks for cancer. And you can consider integrating genetic testing into your practice, which may involve partnering with a genetic counselor. You can visit ambrygen.com for more information, and I thank you for your attention.